Good evening, everyone. Thanks for joining us tonight. I'm Joanna with the Resident Fellow and Student section of SIR. If you're a trainee, visit our website at rfs.sirweb.org. On our website, you can find out more about who we are and what we do, explore our educational resources, as well as sign up for a mailing list if you're interested in being notified for upcoming IR webinars and events. Our webinar topic tonight is Management of Hepatocellular Carcinoma, How I Do It. We are very lucky to have Dr. Dan Brown with us tonight from Vanderbilt for this discussion. Dr. Brown, as a preeminent interventional oncologist, of course, needs no introduction. Any questions you may have for Dr. Brown will be answered at the end of the webinar. Just type your questions into the question box and he'll address them at the end of his presentation. So without further ado, I'm going to pass it off to Dr. Brown.
Thank you very much, and thanks to everyone for coming online tonight. As they're passing this off to me, and I can start going through my slides here, waiting for the presenter thing to come up. I would say if you guys have questions, the end of the talk here can be kind of an ask me anything, where, there we go, okay. If any other questions, it doesn't necessarily have to be related just to this presentation. I'm happy to take questions on any IO topics that are relevant. If I have a useful answer, I'll give them to you. So, click right here. Here we go. Okay, my disclosures are here. And I'm going to talk about one of these grants that just got funded at the end of the talk. It's kind of a future directions thing. The other disclosure I have is that I'm a huge music fan. I don't play a lot of music in the rooms anymore because everyone laughs about, you know, these guys are all, music's all 60 years old. These four guys all have one thing in common. I think it's pretty well established that most, if not all of them, died of hepatocellular carcinoma. John Coltrane in the upper left definitely died of hepatocellular carcinoma. He had hepatitis. Ray Charles, at the end of the movie Ray, it says he died of cancer related to his liver disease. Lou Reed had chemoembolization done before getting a liver transplant, died of complications related to his transplant. And David Bowie, who just died a month or so ago, in a very long article with one of his primary confidants, it said he died of liver cancer. It wasn't really mentioned anywhere else. So this is very becoming more common in the United States and everywhere else. So I stopped playing music in the rooms because everyone likes making fun of me because they don't know who anybody is, and this is one of the things that's been said to me before by one of my trainees. As far as hepatocellular carcinoma goes, this was a relatively rare thing in the United States not that long ago. The number of people getting end-stage liver disease from hepatitis C related cirrhosis in the United States is escalating, and now, even with the anti-Hep C treatments that are now available, with a decrease in the risk of cancer, not an elimination of the risk of cancer. El Sarag just published this. It's just in press right now. I didn't have time to add it to the slide tonight. Non-alcoholic steatohepatitis is going to take up a lot of anything that gets reduced from the antivirals is going to get picked up with non-alcoholic steatohepatitis. By 2020, there's going to be at least 34,000 cases per year in the U.S. This is one of the most common tumors worldwide, with over 1 million cases per year. Back in the day, people used to quote an article from 1980 talking about the history of untreated hepatocellular carcinoma of having a survival of about 3 months. And that patient group was unscreened. There were nobody had ultrasound screening back then. You got identified when the tumors became symptomatic and they're obviously advanced. I'm sure most of you have seen these kinds of tumors that can be 6-7 centimeters in size without any symptoms whatsoever. This is a screened patient population from Asia, and these were the control patients in some randomized trials. And these guys were good performance status. ECOG 0-1 is where you want to have your patient population. Acuda is not used that much anymore, but Acuda 1 is the best. It's a smaller tumor burden, healthier liver. And this group, followed till death, had a median survival of 3 months. So, you know, these things, if you see them at 2 centimeters, you have more than 3 months. But if you take people that have popped up and suddenly got identified, this is still a very, very aggressive disease, even with screening. This is the Barcelona Clinic liver cancer criteria. This is put together by the hepatologist, and the AASLD, which is the American version of the hepatology group, supports this. And this is what we focus on mostly in interventional oncology. This is early stage disease, and these guys, if they can get resected, do, but most patients are not resectable, so they kind of switch over to the transplant group. And we do all kinds of treatments in people pre-transplant, whether it's ablation or chemoembolization. And so this is a huge chunk of stuff that's interventional radiology based, and this is supported by the hepatologists and the surgeons and the transplant surgeons, and that's where we are right now. Now, I'm actually on the NCCN board that writes guidelines for hepatocellular cancer, hepatobiliary cancers. And this gets reworked about once a year. And I work with Ann Covey from Memorial Sloan Kettering. And Ann brought this up and deserves a lot of credit because this really established local regional therapy as the primary option for people who are getting referred to a transplant center either for bridge therapy or definitive therapy. And local regional therapies are recommended by the NCCN, which has nothing to do with hepatology. So these two very separate organizations look at our specialty as the go-to people for treatment for a large number of these cancers. And that's a huge accomplishment in 2016, and it shows how far this subspecialty of interventional radiology has come. So I'm sure most of you people, or most of the audience here is familiar with this, but just to go through what we do. At our practice, we have a busy, diverse practice with, we have both SIR-spheres and THERA-spheres. We do chemoembolization, both with drug-eluting beads or lipiodol, as you see here, the fat fluid level. We have RF ablation, you can see here going into the liver, microwave here in another liver tumor. And, you know, through just a couple incisions, we can kill tumors up to 5 centimeters, sometimes in only about 10 minutes now, which is great. I'm going to focus on arterial treatment first and then move to ablation as we go through this. And obviously targeting is the crux of this. And this is a patient we treated a few years ago. We have this, actually ends up being a segment 4 artery going all the way over here. And this was very easy to follow with arteriography, patient holding breath, getting good diagnostic pictures, and a very hypervascular mass so we could see easily. So, you know, road mapping this is really easy because the name of the game now, and I'm sure you guys see this in your own practices, is get as close as you can to the tumor and treat as little normal liver as possible. That's sometimes necessitated in our practice given the number of people who have advanced cirrhosis, and we have to do that as part of you know, the safest care possible. You know, so some of these will just light up like a light bulb. You can see them, you can treat them. And this person had stable disease, and 3.5 years later had this tiny remnant of tumor. Interestingly, she then developed a new tumor elsewhere in her liver that we had to treat 4 times to get it to stay controlled, whereas this one we treated once. It's interesting how it came back and was completely different biology. We do a lot more targeting now with expert CT than we used to. This is one example why this is a relatively large patient with a tumor up at the dome. A lot of respiratory motion at the dome of the liver, but you can sort of get the idea it's here, but we want to be sure and confirm. This guy had a bilirubin of about 2.8 coming into the room. So we get into the right hepatic artery, and then the question to me at this point is, are we covering the whole thing? When I do expert CT, and there's a bunch of different ways to do this, and you guys may have different variations in your own practices, which are perfectly acceptable. But my way is to get a parenchymogram, try to match the arterial phase of the previous imaging. This patient had a CT. We use MR most of the time. So what I generally do is a 10-second injection. I delay imaging for about 6.5 to 7 seconds, depending on how vascular the mass looks. And then we do the spin, and I just kind of compare it to the previous imaging and make sure it looks like it matches up and we don't have a gap. And this patient, we only took out this very, very distalmost branch, pre-imaging, post-imaging necrotic tumor, liver functions maintained, no worsening in the ascites. Ablation, we can target with either ultrasound or CT. If I can see a mass on CT, especially when it's about 14 centimeters away, my preference is to use CT to target it. We have CT fluoro. Other people may prefer ultrasound, and I got nothing against that. It's just my personal preference. And this is where one of my former fellows, Rob Adamo, who's now faculty at Jefferson, just drilled this thing. I think it was a single pass, and he got right into it and nailed it. This is a pre and post. We usually get pictures about, our preference is 2 months at Vanderbilt. I've seen 1 month after treatment to get follow-up imaging. It's a little variable by institution. Once we get control with either modality, arterial or ablation, we usually get pictures every 3 months or so if they're on the transplant list. If we have good control and they're not going to get transplanted, sometimes we'll stretch that out a little bit further. We're using more microwave. This is a 4.5 centimeter tumor here in a patient who had a really high bilirubin. We were trying to treat this to get him down to Milan criteria, which I'll talk about in a second. We were able to treat with microwave and kill this larger mass that I don't think we would have had the same success with RF. So for those of you in training, the first question, I guess, is how did radiologists become involved in cancer therapy? And the bottom line is, as with a lot of things in IR, there really weren't any better options. If you were diagnosed with hepatocellular carcinoma up into the mid-1970s, you got it and you basically died. If anyone here is from University of Pittsburgh, you're very familiar with the Starzl Transplant Center. Starzl is the guru of liver transplant and did the first series on liver transplant in hepatocellular patients in 1969. 5 of 14, 1 out of 3 were alive, somewhere between 3 and 8.5 months after transplant. Now today that would be horrible, right? If a transplant program had that kind of survival, they'd be investigated and shut down. But back then, that was a huge accomplishment. So that's when the beginning of investigation of transplant for HCC came about. There was no chemotherapy that ever worked at all. And in 1975, there was 2 different articles came out, 175 and 177, and these were studies using doxorubicin. So first off, this is a liver spleen scan with the patient's body habitus drawn over it. So this is a far cry from the PET CTs we have today, but this is what it was like back then. This is way before I was in practice, just as a reference. But you have the costal margins here. You have the palpable mass drawn out here, the patient's umbilicus, areola, port incision site, and this is the spleen and the liver. You can see the spleen much bigger than the liver. So in 1975, the first series came out with a 21% response rate with doxorubicin. That is poor, but doxorubicin became the gold standard drug, and it's kind of ironic that it's still used in all the chemoembolization regimens for HCC, because it never really worked that well unless it was used with embolization, which is a source of discussion at the SIR annual meeting every year. So I talked briefly about cutting it out being the way to go, and this is some of the data. This is recent material from Mount Sinai, New York City, looking at resection and transplant, and people that don't do well have a lot of common factors. Hep C patients are more field carcinogenesis than other groups. Any kind of vascular invasion and bigger tumors, these things are going to be more likely to recur. The transplant group, if you can get them transplanted, they tend to have better long-term disease-free survival than resection. And that goes with RF as well. So there were a bunch of randomized trials done in the early 1990s, late 1980s that did not have good outcomes. And part of that is because we were still on the learning curve as interventional radiologists. Some of these trials had small sample sizes. Some of them had a lot of child C patients. Other medical problems were involved. And the technology was not as good as it is now. The super selection we do now, microcatheters got a lot better in the late 1990s, which is about when I came out of training. And the ability to inject 3 to 4 cc's a second through a microcatheter really developed in the early part of the 2000s. However, success that really drove this in guidelines came in 2002. These are 2 prospective randomized trials, kind of the holy grail of research that showed treatment of hepatocellular carcinoma provided survival benefit over no treatment. This is from Singapore with cisplatin, Lepidol, and gel foam, which I still use. I actually mix gel foam in my chemo mix with Lepidol. Had better survival than control at 1, 3, and 5 years. A second study from Barcelona compared chemoembo to bland embo to symptomatic management. This is a 3-arm trial and was designed to go until one arm reached superiority. Chemoembolization got there first, and that was the take-home message of this paper. There are a number of people out there that do embolization without chemo, or what I call bland embolization. That's my personal term for it. This paper does not represent bland embolization the way it's done in practice. I'll put that out there now. Places like Memorial Sloan Kettering, and I have a lot of respect for the people that work there, they don't use gel foam. They go distally, super selectively, and they use small particle embolization. So this does not equal chemoembolization better than the Memorial protocol. I'm just going to put that out there so everyone understands. Talked about transplant, and part of the problem with transplant was we didn't know, or the surgeons didn't know, where to cut things off and how far they could push things. This came out in 1996 in New England Journal. Interestingly, this is a retrospective study, but this is where the Milan criteria came from. This paper is from Milan, and it found that there was a significant difference in recurrent tumor after transplant if you had one tumor less than 5 centimeters, or if you had more than one tumor, you could have up to 3 tumors as long as all 3 of them were less than 3 centimeters in size. And I think the most important thing of this paper, it said there is an upper limit to what you can transplant before you start losing benefit. Because if you do this, the benefit better be pretty close to the same as people without malignancy or diagnosed malignancy. The upper limit of this remains unknown. At San Francisco, UC San Francisco, they have a protocol that goes more aggressive than this. I think the first tumor can be up to 6.5 centimeters, and the total of 3 tumors has to be less than 8.5, or so. I don't know the numbers exactly. So that's a little bit different, and they have results that are comparable. So we really still don't know the upper limit of this, but that's where this came from. So we see people in clinic, the transplant people in clinic the days we are, they'll sometimes send down same-day referrals. And when I see a patient, I really want to know up front, what's the goal? What are we aiming for? Are we trying to get them to transplant? That's my personal goal, is to get them to transplant, because transplant is potentially curative. Chemoembolization, radioembolization, there will be longer-term survivals than there used to be, but as we know, the best chance of cure right now is transplant. So when we do that, we get referred patients. The first thing we're trying to do is trying to keep people from progressing beyond the Milan criteria while they're being evaluated. UNOS just established a 6-month waiting period for all patients with HCC before they get exception points. There's some people that believe neoadjuvant treatment has benefit to decreasing risk of recurrence. That's not as well documented. We're not going to go into that too much tonight. And we will talk about downstaging, which typically becomes arterial therapy just because the tumors are too big for ablation. The other group is palliation, where you're just trying to keep people going as long as they can. Our surgeons use a term called destination therapy, which I think is very relevant, because that's what we're trying to do. And that can be with or without systemic therapy. The MELD era really began in 2002, and that's when started giving patients 22 extra MELD points if they had HCC within Milan criteria. So it created a couple interesting things. First off, you had to have at least a 2-centimeter tumor or 2 1-centimeter tumors to qualify. So there were people we would follow with tumor board. We actually waited for the tumors to grow a bit so they could get listed without treating them. The other thing is, as this happened, the number of people who got transplanted actually went up 6-fold. And went up a tremendous amount of people. You can see in this graph here, the number of people who got transplanted with exception points went up 6-fold. It was just a tremendous difference. Now, at first, when MELD was instituted, there was an increased risk of death, but overall, the number of people dying on the list actually dropped after institution of the MELD, using the MELD era. I mentioned before this changed recently, and what changed came out of this paper, got published in October 2015, looking at the wait list time. So when we treat people with chemoembolization or Y90 or ablation, part of what we're doing is we're measuring biology of these tumors. If you treat somebody and they come back 3 months later and they've got residual disease or progressive disease, even worse, new tumors, that's probably worse biology, and that may not be somebody you want to treat. And this paper actually showed that in places with wait list times less than 3 months, those people actually had worse survival than people that had longer wait list times. All other wait list times, and the way they broke this up, were the same, but they were all better than people that had a short wait list. So response to chemoembolization now is a crucial test of time to see who's got good biology and who has bad biology, because this is going to determine, you know, whether or not you should get transplanted. Now, we can't control all these tumors. We'll control a lot of them, but the ones that can't, that may be just biology that's just beyond treatment of local regional therapy. This is a paper I think is real important from 2006. If you don't treat somebody, what are the odds they're going to grow, their tumors are going to grow enough that they're going to drop off the list from tumor progression? And what I tell my fellows is the rate's about 1/3 of 1 year. That's a good number, and this is a retrospective look back from 2006, and a doubling time average for these tumors is about 6 months. But 1/3 of 1 year will drop off with no therapy whatsoever. So the American Journal of Transplant paper I just showed here did chemoembolization to keep people on the list in their group of patients, and they found that at 1 year the drop-off rate was 17% with chemoembolization. We looked at this at Jefferson when I was there. Mike Petruzzello, one of my former fellows, did a good job writing this up. He presented it at SIR, and our 1 year drop-off rate was 10%. We actually looked at the different blood types to see if less common blood types had to wait longer and they had a higher drop-off. None of that mattered. We had over 100 patients that we treated in this. And so, you know, this wait period is now going to be crucial. And we're key collaborators with the transplant surgeons. We work very closely with them. Our transplant surgeons are great. They're great to work with. So I'm going to talk about downstaging now. And downstaging is defined at our institution as tumor burden that presents beyond Milan criteria. Our region, which actually is one of the regions that had a shorter waiting time, has an upper limit on where you can start of the UCSF criteria that I mentioned before. So they have to be, if they're beyond UCSF criteria in our region, they're not going to be down, they're not downstageable. At that point, they're destination therapy from the start. And the goal, you know, is to decrease the tumor size, cause tumor necrosis, and then demonstrate stability. And depending where you are, what I see at different places, that's a common scenario, is get maximal tumor kill, have it stay stable for a period of time, and then list the patients. Okay? And that's somewhat similar to what the new UNOS criteria are. But, you know, it was the idea of a test of time to show, okay, there was 8-centimeter tumor there. We killed it. It hasn't grown. It was just big, but it doesn't mean it was bad biology. And again, it's a test of biology with this. And this is for a group of people involved in the medical field, residents, nurses, or whatever. This is kind of a worst case scenario. This is an operating room nurse that got stuck with a Hep C needle. This is from a long time ago. And this person showed up, you know, frankly terrified, you know, for very good reason. They had these 2 very large tumors in the right lobe of the liver. Had to replace the right hepatic artery that you can see here. Got into the right hepatic artery. We did a chemoembolization. This took a couple rounds, and I tell people on average that I tell them that about 50% of people will need more than 1 chemoembolization for successful treatment, and of those people, larger tumors is usually a pretty good sign that you will need more than 1 chemoembolization. And I think this person we probably treated 2 or 3 times, and eventually we got to this picture, follow-up MR showing pretty good tumor kill. So there's been some more interest in downstaging because it's been one of these things that happens, but people don't really feel it's well defined. This review from Lancet in 2012 has, you see underlined in blue here. There's currently no well-defined upper limit for size and number, and that's true. Now, we do have that in the region I'm in now, but I can't say for sure that it's always been that way. And some of these roles of downstaging you can see are really crucial, and this is one that I think I take to heart, which is liver transplantation after successful downstaging should achieve 5-year survival comparable to that of HCC patients who show up within Milan criteria. A systematic review done in 2011, it's amazing how these things, and this is well done, they start off with this enormous number of articles and it gets down to single digits, but that's really what happens with this. They get rid of case reports and review articles and things that didn't match and stuff like that. And they got down to 8 what were called quality articles for downstaging, which is pretty scary. And this is a list of the articles here. I was fortunate enough to write one of these. You can see Will Chapman's the fourth one down there. I wrote that with Will when I was at WashU. A couple things about this. Number one, a lot of these use powdered cisplatin, which we don't have anymore. There's not a lot of Y90 on here. I think there's one Y90 study. And beyond that, there's no drug-eluting bead studies on here. So this is something that is, to me, remains poorly defined as far as how to judge this. Now, going back to that one comment I made about the people who get treated should have outcomes that are equivalent to those within Milan. They went back and went through all the papers. 5 of the manuscripts, you can see at the bottom here, were able to judge that, and the only one of them showed inferior outcomes for people beyond Milan criteria. The other one showed outcomes that were the same. And I think for the most part, this test of time has worked pretty well. The paper I did with Will Chapman, there was one patient who had recurrent disease afterwards. He got a lung metastasis about 4.5, 5 years after transplant. As far as techniques for downstaging, there is one comparison out there that I'm aware of. There may be more at this point, but this is from the Northwestern group comparing a Y90 and chemoembolization of people who were T3, and they had nearly double the success rate of downstaging in people who started with T3 disease with Y90 compared to chemoembolization. And the one thing I'll tell you is that their chemoembolization success rate virtually matched ours at WashU. I mean, so I think that's a pretty good number. About 1/3 of people that are beyond Milan can be downstaged within Milan with chemoembolization, and their Y90 number virtually doubled it. So that's something I do. That's one of the things I use Y90 for primarily in my practice. So I've been focusing a lot on transplant. I'm going to talk more about destination therapy, which is just keep it going as long as we can. This is what I call an all-comers study. This is the WashU experience before I left there in 2007. And this is everybody. This is all the Hep C patients. This is, I'm not Hep C, child C patients. This is people with portal vein thrombus. A lot of these people would now go straight to sorafenib or maybe now palliative care. But we really didn't have anything better back then. Things like palliative care were just starting to be developed. So the whole group survival here is not tremendously high. You have a median survival of 16 months. I'm going to talk about how that shifted in just a minute. However, for people with smaller tumors and good liver function, the median survival was 2 years. And this is similar to other American series. Johns Hopkins using a very similar protocol to us with 3-drug therapy back then when it was available, median survival in 19 months. And Memorial with the bland embolization, I talked about their survival and their approach is certainly not the same as that randomized controlled trial. Their median survival is 21 months. Now, Memorial is not a transplant center, but they do see a number of people with hepatocellular carcinoma, obviously. So been talking about these older things like oil, TACE, and just particles. I'm sure a lot of you practices are using drug-eluting beads and yttrium, and we do some drug-eluting bead TACE. You can see here, this when it first came out was going to be a revolution in therapy because it would be more calibrated. If you get a group of interventional oncology people in a room together and you look at how they mix the oil and the chemo, and how much oil and chemo do they put in together before they start with embolic, and do they use gel foam, or do they use small particles, or what do they do? It's hard to get consensus, and that's one of the reasons large oil TACE chemoembolization, multi-center trials were always very difficult to put together because everyone had their own cookbook and everyone, really believed in the way they did it. So once drug-eluting beads came out, a randomized prospective trial was developed comparing drug-eluting beads to oil TACE. This was done primarily in Europe. It's called the Precision 5 study, and this is a good prospective randomized trial. It has a lot of value here, and it was 212 patients. The conventional TACE was done with weight-based doxorubicin alone and dealer's choice embolic. So you could use gel foam, you could use spherical particles, you could use whatever you wanted. The primary outcome measure of this was tumor response at 6 months after enrollment. So you got up to 4 treatments in 6 months, and at that point, they'd see who responded and who didn't respond. And what's interesting is the outcomes were statistically similar for the entire group. Now, they went in and did a subgroup analysis, and they found that patients that had Child's Class B disease or lesser performance status did do better and had a better response. So that subgroup, you know, at one point I was doing a lot of drug-eluting beads in that subgroup specifically. As I've done more and more super selective chemoembolization, we've had pretty good success as well without a lot of toxicity with oil in that group. So I don't necessarily subscribe to doing it that way. If other people choose to do it that way, I certainly don't fault them. As far as Y90, all comers, yeah, I would say that the outcomes with Y90 between glass and resin microspheres for anybody coming in the room is pretty similar. Bruno Sangro has published a lot of stuff with resin microspheres. This is more of a glass microsphere experience here from Northwestern with a pretty large patient sample. And Child's PUA survivals you're going to see is very similar to chemoembolization. All the toxicities are very similar as well. And this is the first glass case I ever did back in 2008. Big white bulb tumor here and a smaller one here. And this really did respond and shrink down. It's very gratifying. Y90 was like lighting up like a light bulb here and then not nearly so much at the end. This is about 6 months later. And the Northwestern group actually did look at their chemoembolization versus Y90 outcomes. And if I remember correctly, I think the people that got treated with Y90 had more advanced disease. And they still had a longer time to progression than chemoembolization, but the overall survival was not different. There was not improved survival with this. And the survival curves like intertwined so much that they actually did a power calculation to say, okay, let's say we wanted to study this prospectively. In order to get a statistically significant difference between chemoembo and Y90, they would have had to enroll over 900 patients to do this, which is something that's really not feasible. The SHARP trial for sorafenib, which got sorafenib on the market, had, I think, about 600 patients at most, and maybe even fewer. So, I mean, and that was tons of centers. So this is something that's not going to happen. I personally think a lot of the stress that goes on, is this better, is that better? Better doesn't necessarily mean for everybody. And I think that rather than get too focused on this treatment's the best, I think we need to start focusing especially on which treatment is best for this patient. This drives us home again. This just came out, or is coming out in the Journal of Clinical Oncology. And just to show how far, again, this specialty's gone, subspecialty's gone, in the last month, there's been 2 articles by interventional oncologists in the Journal of Clinical Oncology. So kudos to Karen Brown, who did this work herself, got funded. She compared bland embolization to drug-eluting bead embolization, chemoembolization. And again, sample size is not huge. It's a non-significant outcome. I'm sure this will be a point of discussion at SIR in a few weeks. But this is coming out soon, and in their technique there was no difference with drug-eluting bead chemoembolization, and that's one of the statements in the conclusion of the abstract. It talks about the differences between bland and drug-eluting bead chemoembolization. The other article that came out in Journal of Clinical Oncology is the SIR-RFS trial for colorectal Y90. Since we're on destination therapy, it's worth talking about portal vein invasion. The patients that have this can be treated a lot of the time. I will treat people with lobar or segmental clot. Segmental, I don't get too stressed out about chemoembo versus Y90. There's an old axiom that if they have more than segmental thrombus, you don't want to do whole lobe chemoembolization. So if I do chemoembolization in someone with a lobar thrombus, I only treat one segment at a time. So this is somebody that I would treat without thinking and getting too stressed about it. This is an entirely different thing. This is actually called the threads and streaks sign, which was one of the radiology case of the month a few years back. there's no perfusion to the liver here, and the outcomes of main portal vein thrombosis get much more dire very quickly. So this is a much more significant situation and needs to be approached carefully, if at all. And these are the two largest papers on this. Top one's a chemoembo paper from Hopkins with median overall survival of patients with portal vein thrombosis of about 9.5 months. And this is the differentiating factor for me, both for chemoembo and this is important for Y90 as well. If they have well-compensated cirrhosis, it may be worth a shot because you can probably get them about a year. If they're down to child B cirrhosis already, it's poor, and I would find it hard to believe that 4-month survival in that group would be better than observational care. That paper, I don't believe, differentiated the level of thrombosis, meaning segmental versus lobar versus main portal vein. In Y90, the Northwestern group and a couple other centers combined, and they found that people treated with Y90 with branch or lobar portal vein thrombosis versus main portal vein thrombosis had much different outcomes. And again, this is relatively similar. 300 days is pretty close to 11 months. So again, the less thrombus you have, the better. It does make a difference. People with main portal vein thrombosis, again, it's only a few months. And again, I would be hard-pressed to believe that's much different than observation. This is a recent case that was very successful. We did this with Y90. This is a weird kind of a pattern with some infiltrative pattern with some dominant nodules within it in a 52-year-old, otherwise healthy, cirrhotic. She was child A. She was doing kickboxing and Taibo when she first got diagnosed. I mean, very healthy person. And, you know, infiltrative thrombus in the portal vein, the whole right portal vein's out, the main is open. You can see this kind of quasi-infiltrative look with some nodularity on the arteriogram and expert CT. You can see the vein lighting up. We did one session. We treated the whole right lobe and really were aggressive with it. Unfortunately, she also got diagnosed with rectal carcinoma shortly after we did this, and so she's been getting chemotherapy as well. So there may be some combination of outcome from FOLFOX and what we've done, but there's really no viable tumor left. This thing now, the liver's shrunken quite a bit, but this is what's left of that. Nothing is lighting up. The portal vein clot is retracted and actually recanalized a little bit, and we've had a really good result. Now, that's not everybody, but this is the kind of person who was child day walking in, ECOG, you know, 0, just perfectly healthy. This is the kind of person all, you know, for lack of a better term, go for it on to really try to do something aggressive to help out. As far as survival with HCC in the late 2000s, you know, in the 2000s decade, you see all these things. Chemoembo is in white, Y90 in yellow. You see everything's right around 15, 16, 17 months, and this has actually changed in the last few years. It's what I've called an evolution of survival, and just giving an idea, you know, with more focal treatment, super selection, you know, and better technique with expert CT, this is what's been coming out. This is Northwestern again doing small tumors, peripheral tumors, getting way out, super selection, and median overall survival of 53 months. That's a huge difference, right? 53 months versus 17, that's a huge difference. And this is with drug-eluting beads, and this is a huge sample size, 270 patients, and these guys are healthy, good liver function, and they had a 4-year survival. They got censored people, they got transplanted or converted to sorafenib, but, you know, 4-year survival drug-eluting beads. So again, I don't think this is, again, one's not better than the other, but we're doing better all of a sudden than we used to, and this is the evolution of survival. And I think what this really represents in the last 10 years is A, CRM-CT. We can do better, select further out than we used to. The microcatheters are just better than they used to be. When I first started, the instructions for use on these things in 2001 said don't inject more than a cc a second for things that were like 2.4 French. Now we inject 3 cc's a second through those every day. We actually did a project at one point just injecting them until they ruptured. We found a lot of them could go further than they were recommended for. And these things track better, they go out further as well. And I think we do a better job saying no, this is not a good idea. With sorafenib available, or, you know, I mean, the whole world's had enough experience, especially like our colleagues in transplant. You know, people know if it's not a good idea, and you know, just because it's something that could be done, I think people are more willing to say, you know, this is not a good idea for this patient. I haven't talked much about ablation. We'll do that for a few minutes, and then I'll take some questions. This is the killer paper from Riccardo Lencioni, and this is an older paper, but I think it's really important. This is a 57-month Kaplan survival with radiofrequency ablation of HCC within Milan. People had worse survival if they were child B. People had worse survival if they had multiple tumors. This is the paper I use when patients I see in clinic ask me if I can kill their tumor with ablation or Y90 or chemoembo, why do they need a liver transplant? This is why, even with amazing local control, 10% local progression in this Lencioni paper, new tumors developed in 50% of people at 3 years. That's a big problem, okay? And that's the thing. That's why this is not curative. And I personally don't consider RF ablation curative in a cirrhotic patient. Non-cirrhotics, you may be able to call it that, but not in cirrhotics. And this is kind of what you can get. Some of these patients, you get enough of a burn. Some you have to touch up. Sometimes you get really gratifying results with the brick oven effect, meaning that the probe in the soft, squishy tumor, which is surrounded by hard fibrous liver, keeps the heat in there. You can kill harder and quicker with that. But you don't always get this. And so more powerful ablation devices have been a need for a long time. The ability to reliably kill larger portions of tumor has been a crucial thing with ablation in general. The challenge with ablation to me has always been killing enough stuff to get a margin on it. And microwave is starting to get more of a foothold. This is an example of the heat sink problems with RF that you get. These are portal vein branches in an animal model. And you see dead tumor with the vein branches and the heat sink, meaning that you're trying to get this to 100 degrees Celsius and you have 37-degree blood going through there. 37 degrees is relatively cold, and you have a defect in the burn. Whereas with microwave, it just burns right through stuff. Sometimes for the better, sometimes maybe not so much, but it's very effective. This is supplied by New Wave, who I do not have any sponsorship from. And this is different probes that they have. You can see these things burn very, very quickly. The LK probe is the one that burns larger, and you can see the different zones you can get with microwave in an animal model. It's an ex vivo calf model. The group at Wisconsin published this in 2015. RF has really been cut off at 3 centimeters. I tell our residents that 3 centimeters is a good rule for RF of just about everything for the boards. For tumors that are over 3 centimeters, they were able to kill about 90% of them. So I think microwave is getting us a little bit of an extra margin. Perfecting that is still a work in progress. And this is the other thing about microwave is it's quick. And this is the first microwave I did here at Vanderbilt. You see this vascular tumor calcifications in it, and we've only burned this for about 7 minutes, and we were able to get a 6 centimeter zone. We had the smallest margin on it was 1.2 centimeters. So this is very, very gratifying and a quick, happy result. So, this is another schematic of the BCLC criteria, and I have a little arrow going from ablation towards TACE because I think most programs will do more chemoembolization than ablation. Places that do more ablation will probably very vigorously be offended by that, but that's just, I think, the reality of life. And I back that up with this paper. This is an Asian paper. You can see the different BCLC classifications and the amazing survivals we're getting. BCLC A's 5-year survivals of 53%, smaller tumors. Even the B's of 36% 3-year survival. This is great. But when you look closely at their treatment modalities, even in BCLC 0, which is 2 centimeters or less, there was a 6-to-1 ratio of chemoembolization to ablation. I think that really does reflect most practices, and it probably reflects ours too. And I don't think that's bad. I think people have good outcomes with different treatments. So as far as decision making, start to wrap up here. This is my current intraarterial algorithm. We use mostly oil chemoembolization. I think my partners do what I do, both Andrew Lipnick, who recently left, and Phil Banovac, who's now with us here. We do mostly oil TACE. If I need to downstage somebody, if someone's got a big, deep portal vein thrombus, or if they've got lesser performance status, because there's no question that Y90 is easier to recover from. So if it's a little old lady who you think just won't really handle a big post-embolization syndrome, I like Y90. I haven't talked about this during this presentation, but if there's any collaterals like the phrenics or the intercostals where there may be skin communication, I do bland embolization. Reason being, those branches, those arteries can't have skin communicators. I know the group at Stanford has talked about using ice packs to prevent that. I just put particles in alone, and most people tolerate that just fine. Real quickly, I want to talk about future directions. This is a pilot of contrast-enhanced ultrasound that I did at Jefferson with the group there. John Eisenbray is the primary investigator on this from their translational group, and Colette Shaw is one of my former partners, an outstanding endocrinologist. And we found that contrast-enhanced ultrasound as a diagnostic tool shortly after treatment had specificity, sensitivity. It was identical to CT and MR. And this got R1 funded. We're opening the study up, prospective study up at Vanderbilt, Jefferson, and UC San Diego in the next year. And this is a thing that I mentioned. I actually did say this to my chair. If you could assess outcome with contrast-enhanced ultrasound, say you didn't see any flow in the holding area after you did the procedure, say you only had to image those patients maybe 4 months later versus 1 month, which is what most people do. There are about 30,000 chemoembos done in the United States with $2,600 a pop for an MRI. There's a potential savings in that of about $78 million per year, which is not a small amount of money. So I think this study does have some value to try to possibly save money down the road. Maybe you get a good estimate of biology. That good biology patients respond better. The other thing we're talking about here at Vanderbilt, this is a very preliminary discussion, is looking at novel PET tracers to try to determine who will get the best treatment. These are some of my collaborators. Charles Manning is one of the Imaging Institute PhDs. These are two of our transplant surgeons we have a great relationship with, Sunil Geeber-Geese and Seth Karp is our chair of surgery. And we're looking at different tracers. This is a glutamate one. It's a kind of thing that we're very lucky to have at Vanderbilt because we have a very, very aggressive super imaging institute. We can do some of these novel therapies. So I'll wrap up there. I don't want to get too far into the translational realm. And Joanne, you can take over here. And any questions that have come through, you can just feel free to feed them my way.
Okay, sure. The first question is, do you ever use combination therapy, for example, TACE with microwave?
So before I started using microwave, I did that more commonly with TACE and RFA. I think if something's possibly ablatable, microwave will take care of it by itself. I know there are places that do that. Again, it's hard to say don't do that. You know, there haven't been many papers out in the last several years on RFA plus TACE or microwave and TACE. So I can't say there's a data basis to do it, but there's definitely a historic basis.
Okay, and the next question is, could you comment on prophylactic regimens for patients undergoing embolization or chemoembolization with history of biliary instrumentation?
Yeah, there's been a few things described. What we do, we wrote this up at Jefferson. Wasim Khan, resident one, wrote it up. It was in AJR in, I don't know when, a few years ago. We use moxifloxacin for anybody at a higher risk of infection. It's 400 milligrams, I think, once a day. They get it 3 days before treatment, and they get a total of 3 weeks of dose. No bowel prep. And moxifloxacin is excreted in the bile. The paper that we wrote had no infections after 25 treatments, and all the sample sizes in all these papers are small, and this is no different. There's an abstract at this year's SIR with multiple centers with 80 infusions total. There are some infections with the different regimens. To date, I've had 1 infection after embolization with moxi, and I've had 2 after ablation. That's probably a total of about 60 to 65 infusions between Vanderbilt and Thomas Jefferson.
Okay. Our next question is, for oil TACE, how have you handled the international shortage of powdered doxy? Do you use mitomycin C?
We're lucky in that we still have it. Our chemo pharmacy got some. We still have about 65 vials of it. We still use mitomycin C as well. It's a very, very frustrating problem because we ran out before. It's very stressful because I think having that stuff is invaluable. I'm hoping that by one mechanism or another, it will be brought back. The FDA, I've been involved in conversations with the FDA, with SIR as a representative, trying to help Dr. Matsumoto argue on our account as well. I'm hoping by one way or another this is relieved in the next year or so.
Okay, Dr. Rada, next question is, what are your thoughts on Y90 dose escalation, and do you have a protocol for dose escalation?
I'm going to presume that means like the boost treatments that they're doing at Northwestern. Just for history, if you have, and I know a little bit about this, but I'm not an expert, if you have to do a lobar treatment, there's a dominant tumor in one segment, you do like one vial, real high dose in there, and do a lower dose of the whole lobe. I don't have personal experience with that. The guys that, the Northwestern guys, I know them well. I have a lot of trust in them, and they've been really good about documenting their outcomes through the years. So I'd like to see more from them on that.
Okay, our next question is, what is the rationale for adding gel foam to a TACE preparation?
I don't add it. I use it. I put the chemo and the oil in together, and then I put in gel foam. The question is, how do I choose an embolic one over the other? So, anybody that's seen one of the tumor boards at SIR knows that there's a lot of soapboxes that go on. And mine has always been, if we're going to do evidence-based literature, the 2 randomized controlled trials use gel foam after oil. I think it works just fine. And our outcomes are comparable to anybody else's. It's cheaper. I don't think you necessarily need to use small particles to keep the chemo in the tumor.
Okay. Our next question is.
Sorry.
One more thing,
Joe, before I go.
Yeah.
No, it just came to mind. If I see portal vein shunting when I'm putting the oil and chemo in, which sometimes you see even if you didn't see it during contrast angiography, I'll put the gel foam and then I will mix it with the slurry to try to shut down the shunt. So I just wanted to throw that out there. Oh, okay, go ahead.
Okay. Our next question is, some operators have reservations about doing RFA in transplant candidates over concerns for seeding. Any thoughts?
That's an institution by institutional concern. I think you definitely want to, you have to work within your center and what people are comfortable with. I've worked with people that were dead set against it, and I think as long as they follow the same rules and they don't do ablation in the operating room under some theory that it's going to be less likely to seed, I think that's fine. There is a chance of seeding. I've had a patient seed in one of my early microwave cases with a device that's no longer in the market. It can happen, but you have to pick cases carefully. Don't treat people that have like exophytic tumors or immediate subcapsular tumors sticking directly into it. If you can stick around a tumor and bracket it without puncturing it, the no-touch technique that UCLA has written about, that's a good way to go about it to avoid causing problems. But ultimately, IR is part of a collaborative team, and you have to, I always took the approach of just work with what the team thinks is best and don't dig in too much on that, because you have a lot of potential work you can do. I've chosen not to fight that in my practices.
Okay. Our next question is, there's someone asking about the dose of doxy and mito that you're using.
I use 50 of dox and 10 of mitomycin C. The classic triple drug protocol that from University of Pennsylvania that was used for years was 100 of cisplatin, 50 of dox, and 10 of mitomycin C. I used a lower dose of cisplatin personally, 50 milligrams, but the 50 of dox and 10 of mitomycin C I still use to this day. If I do drug-eluting beads, I've seen both 50 and 75 milligrams of doxorubicin per vial used. I've used both through the years. I did not see an increase in biliary complications with a higher dose of doxorubicin.
Okay. And our next question here, we're taught that HCC is an imaging diagnosis, but at our institution, we're doing more liver mass biopsies for pre-treatment genetic analysis. Do you have any comments on this?
Yeah, everything with precision medicine. HCC in some ways is behind because of lack of biopsy. That's also balanced against the risk of seeding in transplant. The risk of seeding after a biopsy is higher than that after transplant. I mean, higher than that after ablation. I wrote a review article on liver and renal cell biopsy in 2008 or so, which had the exact numbers. I think it was a 10 times increased risk, like 1% versus 0.1%, especially with cores. And a lot of the genetic analysis requires huge cores. If someone's not a transplant candidate, and especially if they're going to go on systemic therapy, I mean, I just biopsy the heck out of them. But you know, our tendency for the transplant population is not to biopsy them. And again, this is going to be an institution by institution thing.
And our next question asks, do you ever use redistribution, for example, embolizing segment 4, artery 4Y90?
I have done some redistribution. It's usually in my situation taking out extrahepatic collaterals to try to drive the flow to the intrahepatic vessels. I haven't done a lot of embolizing one segment to get things to the other segments, because I don't know if I embolize segment 4, if the flow is going to go to segment 2-3, or is it going to go to the right artery, right hepatic artery. So I haven't done that much. I think I may have done it once or twice, like taking out segment 4 to treat a right-only tumor, but that's been pretty rare.
So it looks like those are all the questions that we have from the audience. If anybody else has any more questions, you can type into the question box. I think that's all the questions that we have, Dr.
Okay.
Brown. Thank you so much.
Well, thanks everyone.
Yep. Thank you so much for doing this for us.